start our lecture, Psoriasis and lichen rubber planus. Psoriasis and lichen rubber planus. Psoriasis is a chronic inflammatory disease of unknown cause. It is now considered to be due to T lymphocytes mediated disease of abnormal keratinocyte proliferation in genetic predisposed subject. Psoriasis is a chronic inflammatory disease of unknown cause. It is now considered to be due to T lymphocytes mediated disease of abnormal keratinocyte proliferation in genetic predisposed subject. Etiopathogenesis psoriasis. Genetic factors, multifactorial inheritance mechanism and etiologies without any genetic component have not yet been ruled out, though many families appear to exhibit autosomal dominant patterns of inheritance with decreased penetrance. Multifactorial inheritance mechanism and etiologies without any genetic component have not yet been ruled out, though many families appear to exhibit autosomal dominant patterns of inheritance with decreased penetrance. Environmental factors. Infection and a number of physical agents, HIV infection, alcoholism, smoking, ultraviolet light, all can affect the cause, duration, and clinical appearance of plaque psoriasis. Infection and number of physical agents, HIV infection, alcoholism, smoking, ultraviolet light, all can affect the cause, duration, and clinical appearance of plaque psoriasis. Local factors. Trauma. All types of trauma have been associated with the development of plaque psoriasis, physical, chemical, electrical, surgical, infective, and inflammatory types of injury. Sunlight. Moist patient, general considered sunlight to be beneficial for their psoriasis. Trauma. All types of trauma have been associated with the development of plaque psoriasis, physical, chemical, electrical, surgical, infective, and inflammatory types of injury. Most patients generally considered sunlight to be beneficial for their psoriasis. Most patients generally considered sunlight to be beneficial for their psoriasis. Systemic factors. Infection. Pharyngeal streptococcal infection have been shown to produce a clinically distinctive disease flare known as cutate psoriasis. Pharyngeal streptococcal infection have been shown to produce a clinically distinctive disease flare known as cutate psoriasis. HIV. An increase in psoriasis activity has been observed in patients who are or become infected with HIV. An increase in psoriasis activity has been observed in patients who are or become infected with HIV. Drugs. A number of medications have been shown to cause an exacerbation of psoriasis. A number of medications have been shown to cause an exacerbation of psoriasis. Physiogenic or emotional. Many patients report an increase in the psoriasis severity, with physiological stress, smoking, an increased risk of chronic plaque psoriasis exists in cigarette smokers. An increased risk of chronic plaque psoriasis exists in cigarette smoking. Alcohol is considered a risk factor for psoriasis. Alcohol is considered a risk factor for psoriasis, particularly in young to middle-aged males. Alcohol is considered a risk factor for psoriasis, particularly in young to middle-aged males. Endocrine. Psoriasis severity has been known to fluctuate with hormonal change. Psoriasis severity has been known to fluctuate with hormonal change. Systemic factors. Season form of psoriasis. According to the climatic and meteorological factors, winter, intensification in the cold period of the year. Summer and mixed forms are differentiated. Winter type of psoriasis is found more often than other forms. According to the climatic and meteorological factors, winter, intensification in the cold period of the year, summer and mixed forms are differentiated. Winter type of psoriasis is found more often than other forms. Stage. In the progress of clinical development, 3 stages on inflammatory process are distinguished. In the progress of clinical development, 3 stages of inflammatory process are distinguished. Progressive, hospital, and regressive. Progressive, hospital, and regressive. Progressive, hospital, and regressive. For the progressive stage, characteristic features are intensive itching. Development of new papules, peripheral growth of old papules, presence of inflammatory crown around the papula, Koebner phenomenon. Presence of inflammatory crown around the papula, Koebner phenomenon. At the hospital stage, the lesions are compressed, get pale. The desquamation decreases or stops. The pigmentation of the crown takes place around the papilla. Pseudoatrophic Voronoz's crown, and resolution of the lesions, Three-stage progressive hospital and regressive. Clinical classification. Chronic plague type. Acute guttate, inverse, flexor, erythrodermic, regional palms and soles, nails, and sebopsoriasis. Chronic plague type, acute guttate, inverse, flexural, erythrodermic, regional, palms and soles, nails, sebopsoriasis. Pustula psoriasis. Generalized pustula psoriasis, tumbush. Localized pustula psoriasis, palms and soles. Psoriasis with arthropathy. Oligoarticular asymmetrical arthritis. Symmetrical involving small joints of fingers, likes rheumatoid arthritis, classical distal arthropathy involving distal interphalangeal joints, destructive arthritis, mutilans and psoriatic spondyloarthropathy, which is similar to ankylosing spondylitis. Destructive arthritis, mutilans and psoriatic spondyloarthropathy, which is similar to ankylosing spondylitis. Clinical feature. The commonest form of psoriasis in the chronic plague type, which usually presents as brightly. Erythematous scaly plaques at the predisposed area. The extensor affect the type of elbows, knees, sacral area to scalp. They may be associated with no symptoms to moderate pruritus. Excessive dandruff and scaling from the lesional area may be an early complaint. Koebner phenomenon. Three interesting phenomena occur in psoriasis. Any form of trauma may result in psoriasis appearing in the traumatized areas which is known as Koebner phenomenon of isomorphic response. Any form of trauma may result in psoriasis appearing in the traumatized areas, which is known as Koebner phenomenon of isomorphic response. Voronov phenomenon. Well-circumscribed margins, psoriatic plaques are well-defined and have sharply demarcated boundaries. Psoriatic plaques are well-defined and have sharply demarcated boundaries. Psoriatic plaques occasionally appear to be immediately encircled by a pale peripheral zone referred to as the halo of ring of Voronov. Well-circumscribed margins, psoriatic plaques are well-defined and have sharply demarcated boundaries. Psoriatic plaques occasionally appear to be immediately encircled by a pale peripheral zone referred to as the halo of ring of Voronov. Auschwitz phenomenon. Psoriatic triad consists of three consequent phenomena appears after scratching psoriatic papilla. Intense desquamation with silver-white scaling, remaining stearine macula phenomenon. Intense desquamation with silver-white scaling, remaining stearine macula phenomenon. Shiny surface after the removal of scales. Terminal of psoriatic phenomenon. And third sign, drop bleeding, infuser scratching phenomenon of drip bleeding. First, intense desquamation with silver-white scaling, remaining stearine macula, shiny surface after the removal of scales, terminal of psoriatic phenomenon. And third, drop bleeding, infuser scratching, phenomenon of drip bleeding. Chronic plaque type. Plaque psoriasis, the most common type of the disease, is characterized by raised, thickened patches of red skin covered with silvery white scales. Well-circumscribed margins, psoriatic plaques are well-defined and have sharply demarcated boundaries. Plaque psoriasis, the most common type of the disease, is characterized by raised, thickened patch of red skin covered with silvery white scales. Well-circumscribed margin, psoriatic plaques are well-defined and have sharply demarcated boundaries. Acute guttate. Guttate psoriasis is characterized by small drop-like lesions. The small guttate maculopapular scaly lesions still have the characteristic feature of psoriasis, and hence there will be no diagnostic problem. The small guttate maculopapular scaly lesions still have the characteristic feature of psoriasis, and hence there will be no diagnostic problem. Inverse flexure. Inverse psoriasis may lack the prominent silvery scaling because the flexor area affected usually appear as brightly erythematous, homogeneous, well-defined and sharply demarcated plaque or patch with or without superinfection with candida. Flexor psoriasis may lack the prominent silvery scaling because the flexor areas affected usually appear as brightly erythematous, homogeneous, well-defined and sharply demarcated plaques or patch with or without superinfection with candida. Erythrodermic psoriasis is characterized by intense redness and swelling of a large part of the skin surface. Is characterized by intense redness and swelling of a large part of the skin surface. It results from ultra-favorable external factors, irritating treatment, and can be noted in 1-3% of patients with psoriasis, in whom there is usually a decrease in immunological indicators and high allergic reactivity. Due to this, the whole skin takes a bright red color with severe edema. In different places, edema and infiltration are unequally marked. High desquamation, pulling out of the hair, enlargement of lymph nodes, destruction of nails, and separative paronychia are observed. Regional nails. Nail involvement is commonly seen in all types of psoriasis, which can affect the nail matrix and nail bed, leading to pitting, discoloration, subinguinal hyperkeratosis, onycholysis, splinter hemorrhage, circular area of discoloration of nail bed resembling, and oil drop underneath the nail. Oil drop sign is most characteristic for psoriatic nail. Seborrheic psoriasis. Many doctors may not consider the existence of this condition, sebopsoriasis of seborrheic psoriasis. Very often we can encounter a condition in which both psoriatic and seborrheic eczema features are present. We consider this a separate entity because it is not rare. Genetically constituted psoriatics can develop seborrheic eczema lesions at the scalp, eyebrows, and region of ears with characteristic morphologically of psoriasis. Many doctors may not consider the existence of this condition, sebopsoriasis of seborrheic psoriasis. Very often we can encounter a condition in which both psoriatic and seborrheic eczema features are present. We consider this a separate entity because it is not rare. Genetically constituted psoriatics can develop seborrheic eczema lesions at the scalp, eyebrows, and regions of the earth with characteristic morphology of psoriasis. Morphology of psoriasis. Pustular psoriasis. Generalized pustular psoriasis can present in a psoriatic-prone patient who is given systemic steroid for other condition, and upon sudden withdrawal of the steroid, generalized pustular psoriasis will be precipitated for the first time. Occasionally it develops from the unstable nummular psoriasis or acrodermatitis continue after an appropriate irritant therapy or withdrawal of extensive topical steroid. Generalized pustular psoriasis can present in psoriatic-prone patient who is given systemic steroid for other condition, and upon sudden withdrawal of the steroid, generalized pustular psoriasis will be prescribed for the first time. Occasionally, it develops from the unstable nummular psoriasis or acrodermatitis continue after an appropriate irritant therapy or withdrawal of extensive topical steroid. Localized pustular psoriasis of palms and soles, usually present as symmetrical anamorphic eruption of small sterile pustular eruption of hands and feet. They are painful rather than pruritic. Very often brownish thick wall pustules are found. They are resistant to treatment and will be quite disabling. Another form of local pustular psoriasis is asymmetrical involvement affecting distant phalanx with nail destruction. Localized pustular psoriasis of palms and soles, usually present as asymmetrically monomorphic eruption of small sterile pustular eruption of hand and feet. They are painful rather than pruritic. Very often brownish thick wall pustules are found. They are resistant to treatment and will be quite disabling. Another form of local pustular psoriasis is asymmetrical involvement affecting distant phalanx with nail destruction. Psoriasis with arthropathy. Radiological examination of the affected joints may confirm the psoriatic arthropathy. The following fingers are characteristic signs of psoriatic arthropathy: destructive distal interphalangeal arthropathy with bony ankylosis of interphalangeal joints, abnormally wide joint space and well demarcated edges, bony surface, bony proliferation of distant phalanx in grade 2, and resorption of tuft of distal phalanges of hand and feet. Distal phalanges of hand and feet. Investigation. Typical histopathological process: regular elongation of the right ridge with thickening in the lower portion, elongation and edema of the papillae, thinning of the suprapapillary portion of the stratum malpighiae with the occasional presence of very small spongiform pustula, the abscess of granular layer, parakeratosis, presence of Monroe microabscess of Monroe microabscess. Different diagnoses between secondary syphilis, lesions, subjective feelings, psoriasis, each of different intensity, syphilis absent, lesions, psoriasis papules, syphilis polymorphism, except rosella pustula, color of the papula, psoriasis pink, syphilis pupilla red, character of desquamation, psoriasis silver white scales, first in the center and then on the whole papula, syphilis on the periphery of the papula, beads color, predominant localization, psoriasis extends the surface of the limbs, hairy part of hand, syphilis absent. Infection of mucosa, psoriasis usually absent, syphilis frequent, tendency towards fusion, psoriasis characteristic, syphilis absent. Psoriatic phenomenon or phenomenon tried, psoriasis characteristic, syphilis absent. And serological test, negative psoriasis and highly positive secondary period of syphilis. Lichen rubor planus, etiology and pathogenesis. This is an opinion that the disease is infectional by nature as it is successfully treated with antibodies and viruses are revealed inside the cells. Other specialists considered it between neurogenic genesis and think that the stress conditional may be the reason of the disease, as hypnotism and reflex segment therapy is successful in some patients' situation of the lesions along the course of the nerves. Attention is paid to the hormonal deviation and metabolic upset in patients with plain red lesions. Family hereditary predisposition is observed. Attention is paid to the hormonal deviation and metabolic upset in patients with plain red lesions. Family hereditary predisposition is observed. Lichen planus may cause a small number of skin lesions, of less often affect a wide area in the skin and mucous membranes. In 85% of cases, it clears from skin surface within 18 months, but it may persist longer, especially when affecting the mouth or genitals. Classification. Classical lichen planus, oral lichen planus or nails, and atypical lichen planus. Classical lichen planus, oral lichen planus of nails, atypical lichen planus. Atypical lichen planus subdivided: hypertrophic or verrucous form, atrophic and sclerotic forms, pemphigoid or bullous form, lichen rubor moniliformis, acuminate perifollicular form, annular form, lichen planus pigmentosa, lichen planus pigmentosa, actinic lichen planus, actinic lichen planus. Classical lichen planus is characterized by shiny, flat-topped, firm papules varying from the pinpoint size lutein to the larger than centimeter. They are a purple color and often are crossed by fine white lines called Wickham stria. They may be close together or widespread or grouped in lines, linear lichen planus, or rings, annular lichen planus. Linear lichen planus can be the result of scratching or injuring the skin. Although sometimes there are no symptoms, it is often very itchy. New lesions, hyperpigmentation. New lesions may appear while others are clearing. As the lichen planus papules clear, they are often replaced by areas of grayish-brown discoloration, especially in dark-skinned people. This is called post-inflammatory hyperpigmentation and can persist for months. Oral lichen planus. A mouse is involved in 50% of cases and is often the only affected area. The usual areas affected are the inside of the cheeks and the sides of the tongue, but the gums and lips may also be involved. Most common features, oral lichen planus. Painless white streaks in a lake of foam-like pattern, painful and persistent ulcers, erosive lichen planus, diffuse redness and peeling of the gums, desquamative gingivitis. In some cases, oral lichen planus affecting the gums is due to contact allergy to mercury in amalgam fillings on human teeth. The cause can be confirmed by patch testing. In this pattern, the lichen planus may resolve on replacing the filling with the composite material. If the lichen planus is not due to mercury allergy, removing amalgam fillings is very unlikely to result in cure. If the lichen planus is not due to mercury allergy, removing amalgam fillings is very unlikely to result in cure. Lichen planus of nails. Atrophic of sclerotic change may occur after the papules and plaques resolve, Because of its light colors, the blotch-like cicatrical atrophy is called lichen albus. It may be localized on the neck, wrist, chest and abdomen. Microfocal atrophic alopecia may develop on the scalp in case of pseudopelade, which is accompanied with symptoms of follicular keratosis on the extensor surface of the limbs. Little Lacer's syndrome. Hypertrophic form. Lichen planus may affect any area, but is most often seen on the front of the wrist, lower back, and ankles. On the palms and thumbs, the papules are firm and yellow. Very thick scaly patches are particularly itchy and are most likely to areas around the ankles. Hypertrophic lichen planus. Lichen rubor maniliformis, acuminate perifollicular form. Lichen rubor maniliformis, acuminate perifollicular form. It is characterized by large cherry stone in size, lesions reeded like the beds of neck lake. The pustules are dome-like, rounded, wax-like, keloid-like, and are arranged like beads, which creates the impression of narrow keloid bands. In some cases, the lesion resembles a neck lake without keloid-like strands. Follicular lichen planus, also known as lichen perifollicularitis, result in linearid spiny papules around a cluster of hairs. Other form. Bullous lichen planus. Israel blister appear within lichen planus papules or by themselves generally of the lower legs. Actinic lichen planus only affects some exposed sides such as face, neck and backs of the hands. Lichen planus pigmentosa, in some patients oval grayish brown, marks appear of the face and necks of trunk and limbs without an inflammatory phase. Differential diagnosis. Lichen rubor planus and psoriasis. Subjective feeling. Lichen rubor planus intense itching. Psoriasis less intense itching. Predominant localization. Lichen rubor planus flexor surface. Psoriasis extensor surface, higher part of head. Infection of mucous membranes. Lichen rubor planus in 30–40% of patients. Psoriasis commonly not observed. Infection of nails. Lichen rubor planus commonly absent. Psoriasis commonly not observed. Infection joints. Lichen rubor planus not observed. Psoriasis in 25–30% of patients. Form of papules. Lichen rubor planus polygonal. Psoriasis round. Tendency towards fusion. Lichen rubor planus less packed. Psoriasis packed. Additional sign. Lichen rubor planus waxy shine, central groove, Wickham stria. Psoriasis, psoriatic phenomenon. Next lecture, blistering or bullous dermatosis. Etiology and pathogenesis. Etiology and pathogenesis. The group of vesicular and pemphigus dermatosis includes different diseases on the basis of etiology and pathogenesis: pemphigus, during dermatosis, simple vesicular lichen, herpes zoster, exudative multimorphic erythema. The group of vesicular and pemphigus dermatosis includes different diseases on the basis of etiology and pathogenesis: pemphigus, during dermatosis, simple vesicular lichen, herpes zoster, exudative multiforme erythema. There are different etiopathogenetic theories, in particular the viral theory, but it is not completely proved. Recently, autoimmune processes are considered to be of great importance in the pathogenesis. Recently, autoimmune processes are considered to be of great importance in pathogenesis. Discovery of antibodies to intracellular substance in the skin, discovery of antibodies to the intracellular substance in the skin, in liquid of the vesicle and this blood serum, in liquid of the vesicle in the blood serum, in immunofluorescence in intracellular space, in immunofluorescence in intracellular space of the stratum spinosum of epidermis. Immunoglobulin G is found only in the patients with the pemphigus. Peculiarities of the cause of pemphigus. The morphologic basis of the development of vesicles in this disease is acantholysis, destruction of the protoplasmic process of the cells of the epidermis stratum spinosum, weakness of intracellular contact and accumulation of oxidative in this layer, due to which intraepidermal vesicles is formed. Acantholysis underlies Nikolsky phenomenon. By pulling the covering of the vesicle, the epidermis exfoliates outside the boundary of the vesicle of the healthy skin. During severe scratching of the healthy skin between the vesicle, the exfoliation of the epidermis takes place. Nikolsky sign is more expressed in the stage of pemphigus exacerbation. Nikolsky sign is more expressed in the stage of pemphigus exacerbation. The vesicles appear suddenly of the healthy skin or mucosa, then open upon erosion, or their exudates gets covered by crust. The disease has a chronic character, continuous progress, and in the absence of treatment soon results in lethal outcome. Classification of pemphigus. Pemphigus vulgaris, common. Pemphigus vegetans, Pemphigus foliaceus exfoliative, and seborrheic pemphigus. Pemphigus vulgaris is a rare autoimmune disease that is characterized by blister and erosion of the skin and mucous membranes, most commonly inside the mouth. It is the most common subtype of pemphigus, accounting for 70% of all pemphigus cases worldwide, although it is extremely rare in New Zealand, about 1 case per million. Discovery of sunk acanthalytic cells in the smear from the erosion, discovery of immunoglobulin G during immunofluorescence in the intracellular space of the stratum spinosum. Pemphigus vulgaris in an autoimmune blistering disease, which basically means that an individual's immune system starts reacting against his or her own tissue. The building block cells of the epidermis are called keratinocytes. These cells are cemented together in special strictly spots called desmosomes. In Pemphigus vulgaris, immunoglobulin type G, autoantibodies bind to a protein called desmoglein 3, which is found in desmosomes in the keratinocyte near the bottom of the epidermis. The result in the keratinocytes separating from each other are replaced by fluid, the blister. Clinical features Pemphigus vulgaris. Most patients first present with lesions of the mucous membranes, such as the mouth and genitals. Several months later, blister on the skin may develop, or in some cases mucosal lesions are the only manifestation of the disease. The most common mucosal area affected is the inside of the nose, but others include the conjunctiva, esophagus, labia, vagina, cervix, penis, urethra, and anus. The most common mucosal area affected is the inside of the mouth, but others include the conjunctiva, esophagus, labia, vagina, cervix, penis, urethra, and anus. Clinical features Pemphigus vulgaris. Common features of oral mucosal lesions include 50–70% of patients get oral lesions. Blistering superficial and often appears as erosions. Widespread involvement in the mouth. Painful and slow to heal. May spread to the larynx cause. Hoarseness when talking. May make it difficult to eat or drink. Skin lesions appear as the involved flaky blister filled with the clear fluid that easily rupture, causing painful erosion. Pemphigus foliaceus. Pemphigus family are rare autoimmune blistering disease affecting skin and mucous membranes. Pemphigus foliaceus is a rare, relatively benign form of pemphigus. In New Zealand, pemphigus foliaceus is more often encountered than its more serious relative pemphigus vulgaris, though worldwide pemphigus vulgaris is more common. Pemphigus foliaceus is characterized by blistering lesions, one otherwise healthy-looking skin. Blisters tend to form when the skin is rubbed. Nikolsky sign. Blisters tend to form when the skin is rubbed. Nikolsky sign. Causes of pemphigus foliaceus is an autoimmune disease which basically means that an individual's immune systems start reacting against his or her own tissue. The building block cells of the epidermis are called keratinocytes. These cells are cemented together at special strictly spots called desmosomes. In pemphigus foliaceus, autoantibodies bind to a protein called desmoglein 1, which is found in desmosomes in keratinocyte near the top of the epidermis. The result in the surface keratinocyte separate from each other and are replaced by fluid, the blister. Because the blister is very close to the surface of the skin, the blister ruptures easily. In most cases, the antibodies and immunoglobulin type G, but in immunoglobulin A, pemphigus foliaceus, the autoantibodies are type A. Pemphigus foliaceus is sometimes provoked by sun exposure. Endemic pemphigus foliaceus occurs in South America, where it is commonly known as Fogo selvagem. Clinical feature. Pemphigus foliaceus is confined to the skin and there is little or not involvement of mucous membranes. This is in contrast to pemphigus vulgaris, where there may be extensive mucous membrane involvement, mouth, eyelids. The patient is usually otherwise is good health. Small fluid-filled blister first from the trunk. Because they form in the upper layers of epidermis, they rupture very easily and only erosions may be seen. On the face, skull and upper trach, the lesions are often scaly and crusty with a red and inflamed base. A burning sensation or localized pain may be felt. Pemphigus vegetans. Erosions in the skin folds may develop into vegetative lesions which are granular and crusty looking, known as pemphigus vegetans. At the beginning of its development, this form of pemphigus and clinically similar to pemphigus vulgaris and other starts with the appearance of lesions of the oral mucosa from the very onset of the disease. However, attention the drawn to tendency of the bulla to be localized around the nature orifice, the nail, and the regions of the large skin folds, axillary, inguinofemoral, intergluteal, under the mammary glands, behind the earth. Papillomatous growths secreting a considerable amount of exudative are formed later in place of the rupture bulla against the background of the eroded surface covered with a dirty film. The lesions tend to coalesce and form large vegetative surface at place with purulent necrotic disintegration. Nikolsky sign is often positive. The dermatosis is accompanied with the pain and sensation of burning. Active movements are difficult because of sharp pain. Pemphigus seborrhoicus, Sener-Asher syndrome. Pemphigus seborrhoicus belongs to the group of true pemphigus because the possibility of its development into the phthaliaceous or vulgaris variant has been authentically proved. In most cases, however, the disease is benign through of a long duration. The lesions usually first appear on the face and less frequently on the skull, chest and back. Closely arranged grassy crusts are formed against an erythematous background and stimulate the picture of cicatrizing erythematose on the face. Most eroded surfaces are exposed when the crusts are removed. Acantholytic cells are seen in impression smear for this surface. The bulla are often formed unnoticeably and crusts seem to be primary lesion. In other cases, vesicle covered with stratified yellowish crust are formed on the trunk and limbs in sites characteristic of seborrhea. Lesions rarely occur of the mucous membranes, but if this happens, they are a bad prognostic sign. During dermatitis or herpetiform dermatitis, an uncommon skin condition with the peak incidence around 30-40 years of age. Male is more common than female. In Western countries, the disease usually associated with celiac disease. The Western countries, the disease usually associated in Hong Kong's sign celiac disease. Да, я вам перезвоню, я сейчас занята немножко. Через полчаса. In Hong Kong, sign celiac disease is extremely rare. This association is not usually observed. Lesions are composed of excoriate and scabbed intensely itchy papules. The sites of predilection are extensor of forelimbs, buttocks and face. Intact vesicles seldom seen. They are ruptured by self-scratching lesions healed with no scarring. Differential diagnosis: acanthalytic pemphigus during dermatitis. Primary elements: acanthalytic pemphigus, vesicles on the healthy skin, during disease: vesicles, bulla, macula, papula, pustula, polymorphism, characteristic of lesions, flaking, then cover soon opens. During dermatitis, the cover is dense, exists for 7-10 days. 7-10 days. Erosion: acanthalytic pemphigus often extensive, herpetiform dermatitis often less, soon heals. Localization of vesicles: acanthalytic pemphigus intraepidermal, during dermatitis subepidermal. Character of elements: acanthalytic pemphigus monomorphic, during dermatitis polymorphic. Localization of elements: acanthalytic pemphigus unsystematic, blister dermatosis geometric, infection of the mouth cavity. Acanthalytic pemphigus is most patients. The disease often starts with the mouth cavity. During dermatitis, very rare, does not start with mouth cavity. Nikolsky symptom, Nikolsky sign. Acanthalytic pemphigus positive, during dermatitis negative, itch. Acanthalytic pemphigus rare, during dermatitis usually intense. Cause: pemphigus, continuous cause, during dermatitis relapsing. Prognosis: pemphigus serious, in severe cases may be lethal. During dermatitis more favorable, and transformation pemphigus. Zunk antibody cells: acanthalytic pemphigus discovered, during dermatitis not discovered. Reaction with iodine: acanthalytic pemphigus absent, during dermatitis causes intensification. Eosinophilia: acanthalytic pemphigus not high in the blood, during herpetiform dermatitis frequent in blood. And therapeutic effect: absent pemphigus, and among its many cases very favorable effect during dermatitis. Multiform exudative erythema. Is an acute skin disease which is characterized by polymorphism of lesions. Tendency towards relapsing, and seasonal development. Multiform exudative erythema is an acute skin disease which is characterized by polymorphism of lesions, tendency towards relapsing, and seasonal development. Two forms exudative erythema are differentiated: idiopathic, during which the etiologic factors is not known, and symptomatic, connected with defined reason. Medicaments, sometimes vaccines, presence of focal infection, acute infection disease. Medicaments, sometimes vaccines, presence of focal infection, acute infection disease. The characteristic lesions of its dermatitis: supply limited macula and edematous compressed papules, tendency towards peripheral growth and towards fusion into plaques. Pay attention to two colored lesions, pinkish red in the center, bluish violet, cyanotic on the periphery, and impression in the center of plaques, simultaneously with the macula and papula. Blister and even vesicles, and bulla are often formed through polymorphism. Such multiform eruption and its exudative character is the reason for the name of this disease. Herpes simplex. There are 5 types of herpes virus: herpes simplex 1 and herpes simplex 2. The most common type are considered sexually transmitted disease. Herpes virus can be transmitted from a mother to her developing fetus, which may impair neurological development and can be fatal. Herpes virus can be transmitted from mother to her developing fetus, which may impair neurological development and can be fatal. Herpes simplex virus 1, type 1, causes cold sores and fever blisters on the mouth and has been found in genital lesions as well. Herpes virus 2, commonly called genital herpes, causes internal and external genital sores and blisters. Herpes simplex virus 2, commonly called genital herpes, causes internal and external genital sores and blisters. Herpes is a lifelong incurable disease but can be managed with antiviral drugs and safer sex practice. The virus resides deep in nerve cells and it may never produce symptomatic disease or may actively recur throughout a person's lifetime. The latent nature of the virus contributes to its insidious spread. Herpes is a lifelong, incurable disease, but can be managed with antiviral drugs and safer sex practice. The virus resides deep in the nerve cells and it may never produce symptomatic disease or may actively recur throughout a person's lifetime. The latent nature of the virus contributes to its insidious spread. Small 2-5 millimeter fluid-filled lesions of the genitals, buttocks, anus and adjacent areas and the telltale sign of infection. They are painful and often occur clusters. They can also develop inside the vagina of the cervix where they cause inflammation in the rectum. Lesions break open and off for a few days before crusting over and healing. Can also develop inside the vagina of the cervix where they cause inflammation in the rectum. Lesions break open and off for a few days before crusting over the healing. The first symptom, primary infection, can last 3 weeks and are usually severe. Symptoms disappear as the virus retreats to the nerve cells near the sacral region of the spine and becomes later until reactive by a trigger. The virus then travels down the nerve cells to the skin where new sores erupt. Many people experience itching, tingling or heightened sensitivity and tenderness in the area of the original infection a few hours before the sores appear. Some experience pain in the buttocks of knees. Many people experience itching, tingling of heightened sensitivity and tenderness in the area of the original infection and few hours before the sores appear. Some experience pain in the buttocks of the knees. Recurrence can be triggered by minor trauma, other infection including minor upper respiratory tract infection, ultraviolet radiation, sun, condition affecting the nerves of the face, operation of the face nerves, dental surgery, dermabrasion of laser resorption, facing, and many invasive and non-invasive cosmetical procedure. Menstrual cycle flare-ups may occur before the monthly period. Emotional stress. Trigger factors. Herpes zoster is a painful blistering rash caused by reactivation of chickenpox virus. During this widespread infection, which usually occurs in childhood, virus is seeded to nerve cells in the spinal cord, usually of the nerves that supply sensation to the skin. The virus remains in a resting phase in these nerve cells for years before it is reactivated and grows down the nerve to the skin to produce herpes zoster. This can occur in the childhood, but is much more common in adults, especially the older patients. The first sign of shingles is usually pain, which may be severe, is the areas of one more sensory nerves. Often they emerge from the spine. The pain may be just in one spot or it may spread out. The patient usually feels quite unwell with fever and headache. The lymph nodes driving the affected area are often enlarged and tender. Within 1 to 3 days of the onset of pain, a blistering rash appears in the painful area of skin. Sometimes, especially in children, herpes zoster is painless. It starts as a group of closely grouped ram wounds, is a continuous band of the areas of skin supplied by one, occasionally two, and rarely more neighboring spinal nerves. New lesions continue to appear for several days, each blistering or becoming pustular, then crushing over. Herpes zoster occasionally causes blister inside the mouth of earth and can also affect the genital area. The pain and general symptom subside gradually as the eruption disappears. In uncomplicated cases, recovery is complete in 2-3 weeks in children and young adults and 3 to 4 weeks in older patient. Occasionally, pain is not followed by eruption, herpes zoster sign eruption. The chest, neck, forehead, and lumbar sacral sensory nerve supply regions are most commonly affected at all ages, but the frequency of ophthalmic shingles increases with age. Rarely the eruption may affect both sides of the body. In elderly and undernourished patients, the blistering are deeper. Healing may take many weeks and be followed by scarring, muscle weakness arises in about 1 in 20 patients because the muscle nerves are affected as well as the sensory nerves. Facial nerve palsy is the most common result. There is a 50% chance of complete recovery, and this time some improvement can be expected in nearly all cases. In older and undernourished patients, the blistering are deeper. Healing may take many weeks and be followed by scarring, muscle weakness arises in about 1 of 20 patients because the muscle nerves are affected as well as the sensory nerves. Facial nerve palsy is the most common result. There is a 50% chance of complete recovery, and this time sometimes improvement can be expected. Is nearly all cases. It's only operated. Treatment patient, antiviral drugs, treatment patient with herpes zoster or simplex, antiviral drugs, and its general treatment and symptomatic, and local treatment, antiviral creams, aniline dyes, and Put dressing with antiseptic solution. If patient complain of burning, severe painful and edema and oozing. We prescribe this patient dressing with antiseptic solution and aniline dyes and local antiviral ointment or antiviral creams. Today lecture finished. Next lecture dermatology next week. Goodbye.